Okay, I think we have enough attendees. So without further ado, we will start the lecture. So good evening, everyone. So my name is Jen Fan from the ALIGNER Continuing Education team. So first of all, I would like to thank everyone for taking the time to join in today's webinar. The topic of today's lecture is the introduction of ALIGNER. So basically, Dr. Tian, he will talk about the history of ALIGNER and some of the achievements we have been made throughout 20 years of ALIGNER's history. Also, Dr. Tian will briefly talk about our series of innovations with some example case walkthrough. So after the lecture, hopefully you will have a general understanding of who is ALIGNER, what can we achieve, and what kind of innovations do we have. And during this webinar, if you have any question, so please type in the chatting area. Dr. Tian will answer all the questions that you may have during the last 20 minutes of the Q&A session. So if you have any further question regarding the future cooperation, they also provide the regional distributor information in the chatting area. So if you have other suggestion regarding the content of our online lecture or require more product information, please contact the ALIGNER Global Continuing Education team. I will also leave the email in the chatting area. In addition, we will email the recording, the lecture recording link to all the attendees, and the recording is expected to be available on next Monday. So right now, I will go ahead to introduce our speaker for today, the ALIGNER Chief Medical Officer, Dr. Andy Tian. So if you ask anyone who has the best comprehensive understanding about ALIGNER, clear aligner therapy, or ALIGNER innovations, no doubt, Dr. Andy Tian has that title. So statistically speaking, Dr. Andy Tian has been providing the medical support and treatment modification and advice for over 300,000 cases throughout 20 years of his clear aligner experiences. Also, Dr. Andy Tian has over 30 years of orthodontic experiences. He has also contributed to most of the academic research and ALIGNER's innovation. New ALIGNER kit, a comprehensive and his clinical achievements and his service in the clear aligner and to hand over the lecture to Dr. Andy Tian. Dr. Andy Tian, you may start your lecture now. Thank you.
Okay. Thank you, Jian Fan, for your gracious introduction. Hello, everyone. It's great pleasure indeed for me to be here and give a presentation about ALIGNER online today. Just as Jian Fan said, my topic today is ALIGNER and its application, clinical application. Through the presentation today, you may have a brief understanding of our product and technique. There are two parts to my presentation today. The first part is a brief introduction of ALIGNER technology incorporation. The second part is the introduction of ALIGNER and its clinical application. And in this part, we cover the following subtopics. The first one is the treatment option. The second one is angel button. It's a new solution for elastic on clear aligner. The third is we call it an intelligent root system. It's we call it IRS for short. It's about the CBCT data integrated into I also. And the fourth is A6. It's a solution for mandibular advancement. And the fifth, we call it A8. It's a solution for molar distalization case. And the last one is A7. It's a solution for premolar extraction case. And finally, I will land on the Q&A, and please hold your question until the end of the presentation. Okay. Okay. Let's start from the first part. I'd like to give you a brief introduction of Angel Align Technology Incorporation. Our corporation is called Angel Align Technology Corporation, hereafter refers to as Angel Aligner or we. It's a global service provider of clear aligner technology, production, and sales. Since founded in 2003, we have been working on developing high-tech products and developing and to bring beautiful smiles and confidence to people around the world. Let's take a quick look at the history of Angel Aligner. In 2001, we started the R&D of Angel Align with universities in China. And in 2003, the company was founded and started clinical trial of clear aligner. And we only had one 3D printer at that time. In 2006, we got a granted patent of clear aligner in China. In 2007, we set up a first 3D printing line of clear aligner industry in China. And 4 years later, in 2011, 3D printing technology was applied in mass standard production. In 2013, the first version of our client software called iAltho was officially launched. And in 2015, protocol A6 for mandibular advancement solution and A7 for premolar extraction solution were released. And 2016, Angel Aligner Pro. It's a weekly disposal aligner, and the new aligner material must control. It's MC in short, headed to the market. In 2017, we developed a biomechanical analysis platform. We call it MasterForce, came into use. And in the same year, we jointly hosted the first elite digital orthodontic education program with UCLA. And in 2019, Angel button, for elastic on aligner, and A8 premolar molar distalization solution came out. And in 2020, our new R&D and manufacturing center called Trauma Center started construction, and now it has already in use now. The new manufacturing center is programmed to produce over 100 million sets of aligners annually at full capacity. 2021 was a banner year for Angel Aligner. Why? Because we are successfully listed in Hong Kong. And also the aligner material, new generation aligner material, must control S. We call it MCS for short. And also the intelligent root system were launched. Okay, this is a brief history of our company and the development of the industry and the technique. And now I'd like to move to the second part of the presentation, Angel Aligner and its application. First, let's talk about a treatment option. For treatment option, in order to meet our doctor's need for indication and case difficulty of orthodontic treatment, angio aligner treatment options are divided into pro and classic. We have two clinical treatment options in Australia now. The first one is angio aligner pro, and the second is angio aligner classic. In short, the Pro series features all of our best innovations, and the Pro will help you accomplish some of the most difficult cases, such as A6 and A6 for mandibular advancement, and A7 for extraction case, and A8 for mandibular, A8 for the molar distalization case, and intelligent root system, and angio button, also, so many innovation can be used in the angio aligner pro series. And I will explain most of them in the following slide. So I would definitely recommend Pro series treatment as your clear aligner solution for the challenging complicated cases if you are very skilled. The Pro series comes with ultimate refinement and a set of aligner, no limitation. So all put together, you will have enough time and the chance to handle those very difficult cases. So you have 6 years. You can see 6 years. For the classic series, classic series is the primary treatment option for the majority of the adult patient. It is financially friendly of those patients who have limited budget. The classic series also has a standard feature, including the bed rams, conventional attachments, and precision cut, etc. It won't cost you much time to get familiar with a classic because it is familiar to most of the doctor and is similar to most of the market available clear aligners. And we can see there are 3. There's 3 treatment options in classic series. The one is clear aligner classic ultimate, another is classic media, and there is one more, classic light. The classic ultimate has a automated aligner and refinement for complicated cases such as moderate to severe spacing or crowding, and AP and vertical discrepancies, and extraction case, and pre-restorative cases. You can see the expiration time is also 6 years, so it's long. It's long enough for you to finish this case. The classic media, you can see, the treatment typically uses up to 30 aligners. 30 aligners or less, meaning that the whole process of treatment could be completed in less than 15 months. This option is aimed at the moderate cases, such as mild to moderate space crowding, and mild AP or vertical problem, vertical discrepancy, and some simple extraction case or pre-restorative case. The expiration time is 3 years. Also 3 years. So I think it's enough. It's long enough for you to finish this kind of case. And last one is classic light treatment. Typically, it uses up to 15 aligner or less. That means the whole process could be completed in less than 6 months. Yeah, this option is aimed at minor cases such as mild space, mild crowding, and correction of mild space and crowding and restorative treatment. The experiment time also 3 years, so it's enough time for you to finish this kind of case. So for more detail of this chart, we'll send you by email if you want to see to know. So I will not explain this. I will not take more time to give more detail of this treatment option chart. And this is a summary of my experience and advice. The specific treatment option can be based on your own experience as well. So we also provide a one-on-one doctor communication service to solve your concerns regarding any question, any problem during the treatment, such as a treatment option or treatment modification, etc. Okay, yeah, let's move to proceed to the second topic of this part. It's angel button. It's a new solution for elastic on clear aligner. Yeah, we all know that the traditional elastic on clear aligner were cut. Yeah, cut. You know, you must be very familiar with this kind of elastic. Yeah, or lingo button on molars or on some other teeth or hooks. Yeah, there are many problems with it. For example, the first one is the aligner edge is easily deforming when wearing elastics. Yeah, and often might result in the mucosal lesion of the patient. So it's uncomfortable here. And another problem is that, yeah, we usually bound the lingo button or hook on the molars. That is easy to fall off, which will increase the follow-up visit. So it's not so good for the doctors or for the patient. Another problem is that the risk of molar extrusion. Why I say that? Because we know when we use wearing the class 2 elastic, yeah, it has a side effect of molar extrusion that should be avoided in the high angle cases due to the vertical force component. Yeah, because this button is on teeth, not on the aligner. And also the fitting of the aligner is poor on this side, yeah, here. So the tooth movement, especially the canine, the movement of canine will be worse than we expected. And another problem is that about the attachment, compromise of attachment because of the cut. For example, from this big picture, we can see, yeah, we have to compromise a larger attachment to a smaller one because of the cut. Because, yeah, okay. So maybe the smaller, the attachment, smaller attachment is not better to move the teeth for this case. And one more, it's unable to achieve varieties of elastics for the cut. Yeah, for the cut, this kind of elastic is okay. But for this, it's difficult. Or it's it's very difficult for the patient. This is the angio button, a kind of button. But for cut on aligners, yeah, some doctors will design the cut on the lingual side of the aligner. It's difficult to wear for the patient. Okay. Yeah, fortunately, we have a angio button. Yeah, it's a new elastic approach which gives more possibility to the aligner technology. Yeah, you can see it's a transparent, clear. It's a similar material with aligner. It's a transparent, clear. So let's see what's its characteristic. It has the following characteristics. The material is strong enough, robust, clear material. It's made from robust, clear material. And the form, the shape, yeah, it's ergonomic form design, so it's comfortable for the patient, although it is arise from the aligner. And another, it's a integrated structure with the aligner. They are connected very strongly. And also the doctor can place the angio button to where they want it. And also the precise positioning of the attachment of the angio button is AI, yeah, artificial intelligent aided precise positioning. That's very, yeah, it's a cut edge technology. Okay, let's make a comparison of cut and angio button. Okay, you can see a cut. Yeah, it's uncomfortable. I just mentioned it. Yeah, it's easy to deformed, aligner deformed, lead to the oral mucosal lesion, and it's inconvenient for the patient to wear elastic, and it's easily deformed. Okay, and the applicability is limited. But for angio button, it's comfortable, it's convenient to wear. For the patient, it's convenient, very easy to wear the elastic. And also it is reliable. It's high strength. It's not easy to fall off. Also, it has a wide applicability. I will give more information later. Okay, and one more. On cut, the angle of the direction of the elastic are limited. But for an angio button, it's angle free. You can do the elastic at any direction you want. Okay, this is a collection of different type of elastic with angio button. Yeah, this so many kind of elastic that we in the clinical we often this often used elastic can be used by you can use angio button to realize to get what you want. So it's it covers almost all our clinical elastics. But we will make more detail about this application in the future literature. I will not put more detail today. You see the angio button, okay? Anywhere on a liner, yeah, you can place the angio button. So we say angio button goes where you want it to go. That's all for angio button. And now we are coming to the third topic of this part, intelligent root system. In the conventional 3D treatment plan, yeah, this is a conventional 3D treatment plan, and we can only see the crown. Yeah, the crown is the real crown of the patient, and gingiva It's not a real gingiva. It's not a patient gingiva. It's a virtual gingiva. And we only have the movement data. These are the movement data. We only have the movement data of crown. This just crown. Movement data is just crown. We don't have the data of root. To be frank, this is this data, only the crown data is not enough for the doctors to make the right decision. With the upgrading and the popularization of CBCT equipment, more and more doctors are taking CBCT to their patients, and they are eager to integrate CBCT data to their 3D treatment plans, so as to see, they want to see the real teeth, not just the crown, and they want to see the alveolar bone, the jawbone, and some other more details of the patient, some more detailed structures of the patient. And they want to see during the staging the relation between the root and the bone. And they want to know the movement data, not only the crown, but also the root. So we developed this functionality. We call it IRS, Intelligent Root System. Now I will show you a case for you to see, what is okay. I will here. I'll share my screen. The new screen. Okay. Oh yes. Okay. Can you see my screen? Yes. This is I also when they open a ISO file with IRS. This is our IRS design. The first interface display, you can see the initial state of IRS model. Yeah, you can rotate at any direction you want. Yeah, okay. And here, it's very different. It's much different from the conventional one. Yeah, right. And here, you can. Okay. And you will see this three-dimensional structure. The real teeth, yeah, has its own root. The root comes from CBC data, and the crown comes from your oral scanner or PVS impression. Okay, and you can see also we can see the alveolar bone, the jaw bone, and you can here the transparency. You can click here, move it, and also before we review the treatment plan, we should what IRS will help us. Before we review the whole treatment plan, the virtual treatment plan, we should first examine the status of alveolar bone and even the jaw bone or root and okay, yeah, the root and the alveolar relation. If there are, and make sure if there is dehiscence or fenestration already exist, we can look carefully here. Okay, there is a dehiscence. Yeah, dehiscence exists already here and here, and also the lower, lower here and here, the small one. This reminds us that the bone is not enough. Yeah, on the label side of these teeth. So when you make a treatment plan, the label movement of these teeth may aggravate the problem unless you give some necessary operation before orthodontic treatment, or you have to limit the movement the labial movement of these teeth. Yeah, in order to better judging the relation between root and alveolar bone in the initial position, we can also judge the root alveolar bone relation in a final position. Yeah, you can see the final position. This is a treatment plan for this case. Is the first plan we found that you can see there the buccal, the labial root labial side has come out of the alveolar too much. So this plan is very dangerous. So I have to do some modification. And we know that the movement data is very is important for us to evaluate the treatment plan. And here we can see this is a data for individual teeth. You can click here, okay, and move for several steps. These teeth, yeah, there are data here. This is this tooth number. This tooth, and this is crown. We have 3 data, not only the crown, but also center of resistance and the root apex. Yeah, we have 3 data for one teeth. If you want to see more or to see all the movement data of the teeth, yeah, here we can see all the teeth and their movement, crown, center of resistance, and the root apex. If you want to modify, yeah, some doctors like to modify the treatment plan by manually by himself. Okay, there is a function here, modify. You can click modify here, right? Okay, and that would be a we came into the modification interface. Click to T2 position. Oh, there is a list of 2 bar here for you to move teeth. Manually. The upper 4, but these 4 2 are similar and not any differences compared with the conventional function. The important one is that for IRS we have give you more control point or rotation point here. You can see it. Let me click this teeth to see how to modify, to adjust, how to adjust. This is let me hide this. Okay, this is for taping adjustment. Yeah, you can see taping adjustment. Oh, there are 4 points on the teeth. There are 2 on the crown, another 2 on the root. For example, I click here, and you can rotate the teeth like this. So this point will be take as a center of rotation. And here, click here, the teeth will move like this, and same. Yeah. So it's very easy for you to move teeth to your desired position. And this one is crown torque, for you to adjust the torque of the crown. You can see there are 2 points on the root. You can click here, select one, and rotate this direction. Okay. You can move the teeth like this way to adjust the torque of the crown, and this, yeah, like this. This one is for you to adjust root torque. Yeah, root torque. Okay, there are 2 points here and here on the crown. So you select this one. Yes, you can move the teeth like this. More movement of of the root. And this one, yeah, so it's very easy for you to move the teeth to your desired position. These are the there are many more capabilities in IRS because of time I will not put it in more detail, and we have time. Next time we will share more about the IRS application in the future lecture. So that's I show you the case with IRS in our client software also. Okay, we go back to the slide. Okay, wait, go back. Okay, let's move to the fourth topic of this part. Is A6. A6 is a solution for mandibular advancement. Let's see what is A6. Yeah, as we know, we all are familiar with twin block. Yeah, twin block is widely used in the treatment of retrognassic mandible. I know that many doctor of our Australian doctors have ever tried this kind of appliances. You know that the basic philosophy of twin block is the inclined closer plane, which act as a guiding mechanism that causes the mandible to move forward and move downward. Twin block treatment is divided into two parts or two phases. Yeah, two phases. The phase one we know it's an orthopedic phase, just for the mandibular reposition, mandibular advancement. This phase is called orthopedic phase. And the second phase, phase two, we always use after the mandible is stable. The position of the mandible is stable. We'll use fixed appliances to align the teeth and finish the treatment. So this is a conventional way of twin block. And many of the doctors online today, include me, must have use the twin block. Are you satisfied with it? And I know that many doctors and the patient complained the following weak point of twin block. The first is uncomfortable. Yes, it's obvious. Yes, it's a very large size. So it's uncomfortable for the patient. Secondly, yeah, it's unaesthetic. Yeah, it's I'm sure that's for sure. And the third is that it's inconvenient for the doctor or for the patient. The patient have to have more frequent visit, a follow-up visit to the doctor, and the doctor will have to adjust or trimming the plate, and so it's not so convenient for the doctor and for the patient. And the last point is that the orthopedic and orthodontic, the two phases are separated. In the phase one, in orthopedic phase, the aligner will not align teeth, just its orthopedic function to just to reposition the lower jaw to the forward position. The alignment will not do in this phase. In the phase two, it's just orthodontic treatment, so which prolong the course of the treatment. Is it possible to combine clear aligner with twin block mechanism? Yeah, we tried, and we think A6, our A6 is what we try to do successfully. This is the aligner, A6 aligner, upper and the lower, and this is the aligner wearing in the mouse. Their upper and lower plate and block here, the occlusal client plate here, and let's see the benefit of A6. The comfortable, yeah, it's comfortable compared with the traditional twin block. Aesthetic, sure, it's convenient. Yeah, the patient just wear the aligner step by step. Yeah, it's they don't need to visit the doctor frequently, so it's convenient for the doctor, for the patient, and also it's efficient. Yeah, because although it's also we have two phase, but phase one we can start the orthodontic treatment simultaneously, so that's shorten the treatment time. So this is aligner, and this is aligner wearing in the mouth. Let's see what's the protocol of A6. That has three. Yeah, first is the bite construction. The second is attachment design, and the third is the treatment facing. Let me put it in more detail. What is bite construction? Well, we all know that bite construction in twin block. Yeah, the first protocol is also bite construction, and we know that bite construction and the register, bite register is very important for twin block, and also it's the same. It's also equally the same for A6. Yeah, you may use the bite wax and even MPS, and I know some doctor, or many doctor in Australia, they submitting cases to us. Yeah, they use this kind. This is project bite gauge. Yeah, bite gauge. Yes, I think this is a very good product, a very good appliances. Yeah, it's a very good helper for us to get the ideal or a qualified bite register. There are some criterion for bite register for A6. The first one is a vertical opening in the premolar area. Yeah, it's 4 to 6 millimeter. This is a A6. It's a block. Yeah, you can see it's a block because we need enough space, enough height, vertical height to place the block. So 4 to 6 millimeter is the standard. And for the anterior opening, 1 to 2 millimeter is enough. Don't open it too much, too high. Yeah. And for the mandibular advancement, we need overcorrection 2 to 3 millimeter. Yeah, you can get a mild class 3 molar relation. So this is very important for you to submit the bite register. This is okay. The second protocol is about the attachment design. What's a special design of the attachment for A6? First, as we know that the retention is very important for A6 aligner, because the aligner will what we want is the effect of the bone effect, not the teeth effect. So we need a very strong retention of the aligner on the arch. So the attachment will be more than the traditional aligner. So you can see on the buccal side and the lingual side, not all the lingual side, but one or two lingual side, we have designed the retention attachment on posteriors. And for anterior teeth, especially on the lateral incisor, we will design a beveled attachment. So this is the attachment design for A6. What about another one is a treatment facing. The treatment is divided into two phases, but the two phases is different from the two phase of twin block. In our A6 two phase, the phase 1 is also orthopedic phase. It's what we do in phase 1 as follows: repositioning of the mandible. That means the mandible advancement, and at the same time we will do arch expansion and preliminary tooth alignment, and level the curve of speed as possible. And these are done. This were undertake and simultaneously when we reposition the mandibular. And in phase 2, we continue leveling the curve of speed and tooth alignment and detailing the intercuspation. And also, we will design class 2 elastic to maintain the mandibular position. Needs some time it's very important for the position, the mandibular position. So sometimes class 2 elastic are necessary. Okay, this is a protocol of A6. Now I'll show you a case treated with A6. This is a 12-year-old girl, and her chief complaint is the mouth protrusion. Mouth protrusion. This is profile before treatment. There is no facial asymmetry, and the lip, you can see the lip incompetent, and the lower lip trapped at rest behind the upper central incisor. This is our intraoral view. You can see all prominent teeth from first molar, and they are mild crowding, upper and lower arch, but there is a large overjet, almost 10 millimeter overjet. And the buccal, you the buccal side, buccal relation was end-on class 2 relationship on both sides. The panoramic film, we can see the presence of the second and the third molar is developing. There is no other problem. A symptometric analysis, we can see the A and B angle is 7.2. This suggested a moderate class 2 skeletal pattern. And also we can see the upper incisors proclined, a lot. And lower incisors also is proclined. And the upper lip to E line increased. These are the facial profile and intraoral view when the mandibular posture forward. Before treatment, we ask the patient to protrude their mandibular forward to see if the profile got improved. This patient, we can see the profile got improved. So this suggests to us that this is a case suitable for A6 treatment. I see a diagnosis. It's angle class 2, division 1, skeletal class 2, mandibular protrusion or mandibular retrognism, and crowding, deeper wide overjet, and the lower and upper incisors proclined. Let's see the main objective for phase 1. Yeah, reduced overbite over jet. Preliminarily choose alignment and level the curve of speed and achieve class 1 relation. Yeah, this is the most important task in phase 1. Okay, the treatment plan for phase 1, mandibular advancement, upper arch expansion. Yeah, expansion. We have to must do this. It's in order to for the lower jaw to move forward and stable. And upper first molar distalizing. For some cases, if we need some more space, or we cannot move the lower jaw too much, sometimes we need to distalization the upper molar. In this case, we distalize a little. And correction the malpositioned teeth simultaneously. Yeah, this is very important. Simultaneously align some teeth, level the curve of B as much as possible. This is the treatment plan for phase 1. Okay, this is a ISO 3D treatment plan, and we can see the first attachment on the lingual side, attachment buccal side have more posterior teeth. And expansion and the posterior upper expansion, and we have a little molar distalization, upper molar distalization. This is a block, upper and lower block. Okay, let's see. This is step 1. Yeah, just wearing the new aligner of A6 new aligner. You can see. Okay, this is a interface of upper and lower plate, a block. It's clear, and lower jaw was locked in the advanced position. This is a visual view after wearing step 12. The first stage, the first phase 1, we designed step 12 step for the patient. So this finish the post-treatment of phase 1. You can see the profile, improved a lot. Intraoral view, we can see the alignment also, the tooth alignment also improved, and we can see the contact point, the lower, the molar, first molar, and the canine and the incisor, have established, the contact had established the molar and incisor, but we have open bite in the premolar area. This is the most of the case after most of the A6 case or temporal case after phase 1 treatment. It's a comparison of the profile. You can see the profile improved a lot. Upper and lower lips to the E line achieved normal, almost normal. And this intraoral comparison. The upper is the pre-treatment, lower is after post-treatment of phase 1. You can see, establishment, the occlusal contact on first molar and incisor, and open bite in premolar area. And mandibular now is stable because there has contact here, close contact here. Upper and lower arch comparison, tooth alignment improved, not completely. This just do some alignment. Overbite over jet decreased, especially over jet decreased significantly. So we can move on to the phase 2. The main objective for phase 2 are relieved lower arch crowdings, level and align the arches, achieve class 1 canine and incisor relationship, detailing and finishing. Now let's see the treatment plan for phase 2. continue to align teeth, level curves B and the close remaining space. Because there are some space because we distalize the molars, so there's some remaining space. And detailing the dentitional intercuspation. And also we design class 2 elastic to maintain the position of mandible. And finally, retention with vacuum formed another retainer. Let's see the I also 3D treatment plan for phase 2. You can see the close the space in upper arch, distally movement of premolar, canine, and retract the upper incisor to correct deep overbite, deep overjet, and detailing the dental intercuspation. Okay, let's see the comparison of pre and post treatment. This is the facial view comparison. Yeah, you can see the proportion are more harmonious. Yeah, yes, it's more beautiful than before treatment, and the patients played a more pleasant smile arc. Yeah, the smile is beautiful, and the profile improved much. So you can see the profile. The upper lower lips to the E line achieved normal. Let's see the intraoral view comparison. The upper is a pre-treatment, the lower is after treatment. You can see the lateral relationship, molar and canine got bilateral. We got a class 1 bilateral, and upper lower midline coordinated, and overbite, overjet, or normal. This is the upper and lower arch. We can see the arch form are coordinated, beautiful arch form, and overjet, overbite, normal. Fully alignment. Yeah. So it's very good result. The panoramic photograph, we can see, that is a very good root parallelism after treatment. And the second molar, the upper second molar not erupted completely, and the wisdom teeth are still developing. Let's see the saphenometric analysis. It shows that the AMB angle, it increased because the mandibular advancement. The AMB angle increased by 4.2 degree, and AMB, you can see AMB is reduced to 3.7 degree, and also GOGP, the distance, increased 4.46 millimeter compared to the pre-treatment, indicating a favorable jaw growth, which proved that A6 was effective in this patient. Also, we can see the inclination of the maxillary incisors also got corrected. Yeah, here. Okay, let's see the superimposition. The superimposition at the cranial base showed a mesialization of mandible with the retraction of upper lips. You can see upper lip was retracted, and the superimposition on the maxilla showed a retraction of upper incisor, and superimposition on the mandible showed a mesialization and growth of the mandible. So it's very efficient for effective treatment for this patient, for this adolescent. Okay, let's make a summary for this part. We can see the benefit of our A6 is comfortable compared with the traditional twin block. It's comfortable, it's aesthetic, and it's convenient, efficient. So we compare with the twin block. So more and more people, more and more adolescent or teenager prefer to use A6 to treat their problem. Okay, this I'd like to move the next one is A8. It's a solution for molar distalization case, for molar distalization. Let's see, molar distalization is frequently used. There are many different ways to distalize molars. The clear aligner I think is the best choice. I think, but how we achieve this predict result with A8? What is A8 about? Yeah, there are 4 key elements for our A8 protocol, for our A8 solution. The first is this one. I think this one should be the first. Posterior anchorage control, and anterior anchorage control, and posterior height or vertical control. It should be the vertical control, and also the anterior over bite control. This 2 is a vertical control, and this 2 we call it's an anchorage control. Okay, let's see what is protocol for A8. Also, it has 4 protocol. The first one is attachment design, and the second is sequential staging, and the third is elastics design. What's a special for elastic? And the last one is aligner shape design. Let me put it in more detail. First, this is a typical design of A6. Okay, you can see, okay, to distalize the upper molar, the teeth are moving backward sequentially, not distalize more than 3 teeth at once and one quadrant. So the movement staging, you can say it's like a V. Yeah, you can call it a V pattern. And also we have a class 2 elastic on agile button. Agile button, you can see here and here. The agile button is on aligner, not bounded on teeth. Yeah, that's very important. Okay, let me put it in more detail. The protocol of A6. The first one is attachment design. Attachment design, for these 3 teeth, we use optimized. This is a default attachment design. Optimized, we call it optimized. This kind of, this attachment, we call it optimized attachment. It was designed by the software automatically. This attachment on the second molar will only, let me put it this way. They optimize the attachment on premolar from the very beginning, but on the second molar, the attachment will coming at the step when the second molar stopped distalizing. Then we design the attachment. Some doctors prefer to use a conventional rectangular attachment. Yeah, that's okay. You may continue using it. It's okay. But this is optional. Yeah. If you don't have any preferences, we will use optimized attachment for default. Another protocol for posterior and anterior acreage control is the first one is a sequential staging. Another one is elastic design. The design on button, this is for class 2, to move upper molar distally. If you want to distalize lower molar, then we will design class 3 elastic. And one more important is aligner shape design. You may wonder, what is aligner shape design? You can see the difference. Yeah, it is a special treatment by trimming off the end of the aligner, 1/3 of the aligner, starting from the step that the second molar stopped moving distally. Do you understand? It's when the second molar stopped moving distally, the aligner will trimmed 1/3, this to 1/3, the end of the 1/3 of the end part of the aligner. To do this, why we'll do this kind of treatment? It's a consideration of the acreage. Another protocol for posteriors and anteriors vertical control. Yeah, vertical control for the molar, especially the molar will distalize along the curve of compensation, not just translation. It's a compensation along the curve of compensation to prevent overbite deepening. For this, we have this compensation for the anterior teeth. It's a kind of compensation for the vertical control to prevent the deepening due to the intermaxillary elastic. Okay, I will show you a case treated with A6. This case is a 23 years old female. Chief complaint is crooked teeth. Yeah, the extra examination revealed that the frontal view, we can see it's a asymmetrical long face. The right side is higher, is fuller than the left side, and the left angulus oris is slightly higher, slightly higher than the right. Yeah, and the mentalis muscle, a little tension. Upper midline is the picture is small. Upper midline shifted 1 millimeter to the right, and the chin deviation to the right side a little. The chin, yeah, deviates to the right. Lateral review, we can see it's a convex profile, a mentalis hyperplasia. It's a long face, high angle face. The intraoral view, intraoral examination revealed that the incisor relationship was class 2, and deep overbite, and deep overjet. And the buccal segment, we can see its relationship is end on both sides, end on class 2. And the curve of SB was exaggerated, deep curve of SB. From the panoramic radiograph, we can show us is a complete dentition. The 4 wisdom teeth are all impacted. The condyle morphology is on both sides asymmetrical. It's different. And the length of the ramers were inconsistent. The alveolar bone are quite normal, Let's see the sphenometric analysis. Skeletal class 2, you can see, yeah, it's a joint-based relationship is class 2 with retrognathic mandible, yeah, mandibular retrognathic. the upper and lower incisors straight. It's straight, and it's a high angle, a steep mandibular plane, high angle case. The diagnosis: angle class 2, skeletal class 2, and facial prognathism, the mandibular retrognathia, and also has crowding, midline shift deviation, and deep bite, and deep over jet, and deep over bite. The treatment goal: correct class 2 molar relation, resolve crowding and reduce overbite and overjet, remain a facial pattern. This is very important because this is an adult and have some many skeletal problems. So because she reject the surgery, so for orthodontic treatment, we will not change the facial pattern. The treatment plan: extract of the 4 wisdom teeth. We use A8 protocol, distalizing the upper and the lower molar to create space and achieve a class 1 molar relation. Also level the curve of B by retruding the lower in anterior teeth. Because it is a high angle, so the extrusion of posterior are undesirable. And there are 2 millimeter IPR on lower arch. Let's see the also treatment plan. Okay, we can see the sequential movement, distal movement of upper molar. Lower molar, there has not so many distalization of lower molar. IPR in the anterior, lower anterior teeth. Class 2 elastic. And this, I will not share the duration of the treatment, the progress of the treatment, and just see the comparison of pre and post treatment. This is a facial view of the patient. The frontal view and the lateral view not changed too much, but the smile, I think smile is more pleasant, more charming. And the intraoral view show that we got the class 2, the class 1, from class 2, from and on class 2 to class 1 molar relationship, and the crowding was corrected. Upper and lower dentition, midline coordinated, and overbite overjet were normal. Let's see the upper lower arch. Yeah, crowding corrected, arch form, very beautiful arch form, and was coordinated. The panoramic view shows that a good root parallelism, and the alveolar bone kept almost unchanged. Yeah, there's not root resorption, and 4 wisdom teeth extracted. This is very important for molar distalization case. Wisdom teeth, most of the wisdom teeth should be extracted. Now the cephalometric change. Also, we can see some change. Yeah, the lower incisor was proclined. Yeah, proclined a little, and also the incisor angle was normal. From the superimposition, we can see from the maxilla. Yeah, this is the maxillar superimposition, and maxilla show the distalization of upper molar, and superimposition of mandible show the proclination of lower incisor, because the lower molar didn't move so much, so we didn't find, cannot see it in the superimposition. Let's make a summary of this part. Just remember the A8 protocols. Attachment design. You can use default, optimized, or you prefer to use your the traditional one, the rectangular. Yes, that's okay. And sequential move, then sequential molar distalization, and the elastic design, and the aligner shape design. Yeah, so trimming the distal, the distal third, 1/3 of the aligner when the second molar stopped distally, moving distally. And also we have the vertical compensation for the molar and also for the anterior teeth to prevent the change of the vertical change of the facial pattern, and also to prevent the dippling of the anterior teeth because of the elastic intermaxillary elastic. Okay, let's move to the last part of today's presentation. It's A6. It's A7. It's A7. It's a solution for premolar extraction case. It's a more complicated case. As we know that for clear aligner technology, there are many challenges in extraction case, such as the loss of torque, loss of torque, and leading to the deepening of the overbite and distal inclination of canine, and development of buccal open bite here, and the tipping, and the second premolar canine tipping to the extraction site. We call this it's a so-called Boeing effect. It's very difficult to deal with. What we can do to respond to these challenges? So the angel aligner will develop the A7 premolar extraction case to meet this challenge, to solve this problem. And there are 4 key elements of A7. The principle of A7 is under the guidance of Master Force. Master Force, I just mentioned in the introduction of our company. Yes, it's we develop by our own. It's a mechanical analysis platform, biomechanical analysis platform for aligner technology. So this A7 is under the instruction of this platform. The key element is the 4 key elements. First one is accurate control of posteriors. The second is torque control of anteriors. And the third is bodily distalization of canines. And the fourth is a vertical control. It's a very important aspect for extraction cases, also for aligner. And okay, let's see the protocol of A7. The first one is the attachment design. Let's see the attachment design. Yeah. Okay, like we can see the teeth, canine, and this is a first premolar extraction case. You can see we have attachment on canine and posterior teeth. It's a vertical rectangular attachment. This is a conventional attachment. We're still using it in A7 cases, A7 extraction cases, and especially on the first molar, there are double vertical rectangular attachment. Oh, okay. This is sometimes we use a horizontal one, especially for those the clinical crown is too short. It's don't have enough space to place a vertical attachment. The horizontal one is then an option. This is the attachment design. Protocol for accurate control of posteriors, what we will do. We know that treatment field, especially for orthodontists, very familiar with trained mirror field. In this technique, we know that one of the core protocols for treatment field technique is accurate preparation at the initial phase of treatment. That the posterior teeth will be taping backward one by one. In our A7, we borrowed this protocol and designed distal tipping of posterior teeth at the initial stage of the treatment. You can see posterior tipping backward, one by one. The second molar, the first molar, and then the second premolar. This is accurate preparation. We can call it accurate preparation. Okay, let's see. This is the original position. This is the final position. We can see original position. This is the angulation of the posterior teeth. And after the final position, the posterior teeth are taping backward for 5 to 6 degrees. How to get a bodily movement of distalizing of bodily movement of canine? It's very important for the extraction case. What we do in the A7. This is the original position. This is the angulation of canine in the original position. And this is the final position. You can see there is overcorrection, angulation overcorrection of the canines. So we call it an overcorrection of angulation of canine. Another key element is to the torque control of anteriors. Okay, the protocol for this element is overcorrection of torque of anterior teeth. This is a original position. You can take it as a normal torque. This is the final position. Yeah, there we add a 10 to 15 degree positive torque overcorrection was built into the final position to compensate for the loss of incisor torque during the extraction. As we know that many of the extraction cases, they are we need to retract anterior teeth a lot. So the torque control is very important for this kind of teeth in order to get a normal torque after the treatment clinically. The last one for the vertical control. The protocol for vertical control is reverse curve of speed. Yeah, this picture you can see original position is a deep curve of speed in the mid lower arch, and in the final position we'll design it's a reverse curve of speed to correct the deep bite, to correct the deep overbite, deep bite to curve the to correct the deep curve of speed and the deep bite. Okay, this is a principle of our A7. Let's see, I will show you a case treated by A7. This is a adult, 32 years old female, compliant chief complaint is teeth protrusion and protrusion profile. On the lateral view, we can see upper and the lower lip protrusion. Intraoral examination revealed the class 1 molar relationship and a moderate crowding in upper arch, mild crowding in lower arch, and upper and lower midline were inconsistent, and the deviation was about 2.5 millimeter. Overbite over jet, it's normal, and the curve speed is normal. The panoramic radiograph showed it's a complete dentition. This wisdom teeth was impacted, and the condyle form, see, is both sides asymmetrical. The alveolar bone was quite normal. The cephalometric analysis showed the main problem is the upper and lower incisor procline. Yeah, it's a class 1 skeletal relationship. Most of the problem, the main problem is the inclination of upper and the lower incisors. The diagnosis: angle class 1, skeletal class 1, bimaxillary protrusion, and upper and lower incisor proclined, and crowding, midline, deviation. So the main objective of treatment is correct crowding and teeth malposition. The most important is to resolve the bimaxillary protrusion and improve facial profile. Okay, the treatment plan: extract the 4 first premolar and 4 wisdom teeth. It's too many teeth to be extracted. And also use A7 protocol. And the maximum molar acreage, this is important. This means after tipping the posterior teeth, after finish tipping posterior teeth, the posterior teeth will stop moving, just move the anterior teeth. This is virtual, we can call it virtual maximum molar acreage. Now let's see the quick look. Take a look at the I also design animation. I use a high speed, so you can see the attachment design, and tipping forward. This wisdom teeth were not extracted at the initial of the treatment. During the treatment, it was extracted. So you can see the preparation, acreage preparation of posterior teeth, and then after finishing the acreage preparation and the distalized canine and then incisor were spread out and aligned and retract gradually. You can see the molar no longer move after acreage preparation, just stay there. Oh, let's see. I will not put more detail of the duration of the treatment, the progressive of the treatment. Let's see the result. It's a comparison of facial profile, facial view of the pre and post treatment. We can see, the smile is more pleasant, and the profile, especially the profile, got improved a lot. This is her main complaint. The intraoral view, we can see the crowding, the teeth, the arch was aligned, very good arch form, coordinated, and also the midline of upper and lower arch coordinated, and class 1 molar relationship was maintained, and the proclined incisors, become straight, yeah, were retracted. Let's see the panoramic film. Yeah, the root parallelism fairly good. Yeah, it's fairly good. And the alveolar bone almost unchanged. No evidence of root resorption. The 4 wisdom teeth was extracted finally. This is a stephanometric analysis and superimposition. We can see the most significant change is uprighting, is a retraction of upper and lower incisors, and become from a very protruding, very become straight, yeah, and also the profile becomes straight also. Oh, let's summarize the A7 protocol. What is the first one is attachment design. It's a conventional attachment, but in the different, what's the different is that we place 2 rectangular attachment on the first molar. And now we are developing a new optimized attachment for A7. If you are interested, you can use a new optimized attachment in your new case. And another protocols is the posterior taping backward. It's for the anchorage preparation. And another one is about the canine angulation over correction of canine angulation. In order to move the canine to get a bodily movement. Almost all what I want to share with you today, and I want to make a summary for today's presentation. Today, we know that Angel Aligner is world's second largest company in clear aligner tech industry, and we are currently promoting Angel Aligner Classic and Angel Aligner Pro in Australia, and we developed Agile Button. Yeah, Agile Button. It's a new solution for elastic on aligner, and also we develop intelligent root system for you to integrate your CBCT data into your treatment plan. And also we develop A6 for is a solution for mandibular advancement, and also A8, a solution for molar distalization case. The last is A7. It's a solution for premolar extraction case. And we are also committed to continually enhancing our products to better meet the different needs of our doctors. And we expect more and more Australian doctors trying our product and our service.
Okay.
Well, can we, okay, if you please, Jianfan, you will.
Okay, thank you, Dr. Tian. Thank you so much for the excellent lecture. So right now we will move ahead to the Q&A session. So the first question is, could you share your experiences when utilizing the tags and hooks, where and when to use it? Maybe talk some your personal experiences with that, plus some clinical experiences with angel bottoms.
Yes, thank you for your question. TADs, yes, in some cases, I will try TADs to assist it to get better, to get a more efficient treatment result. And for those cases, for example, for the it's very serious deep overbite cases, we need more a lot of extrusion of anterior teeth. So it's if you just use aligner to intrude the anterior teeth, it's more difficult. It's difficult and it's not so efficient. So this under this circumstances, I will recommend use TAS to help me to open the deep bite, and also for the case for A8 case for molar distalization, and I will use TADs for those who need to move molar more than 4 millimeters, and so it takes time. So I wanted to improve the efficiency of the aligner. So I will use TADs, and some case for extraction case, for extraction case, some cases with the canine, the angulation of the canine is tipping, the crown is tipping distally. For this case, it's difficult to control the angulation while you're moving the canine distally a lot. So this in this case, I will use TADs and power arm to help, to assist, to move the root of the canine more distally, and for some cases, extraction case, we have to move long distance molar mesolarization. For molar mesolarization more than 3 millimeter, I will use TAS to help the bodily movement of the anterior of the posterior teeth. That's my experience. Hello.
Thank you so much, Dr. Tian. And here is another question from Dr. Kang. So, how would you control the molar tipping when extraction the lower 5?
Lower 5 is this kind of case is rather difficult, a rather complicated case, and if in this case, this kind of case, usually I will move the teeth not a little slowly than the original, than the first premolar extraction case. It should be slow down the speed. You should have more staging, and it depends on the how much you move the molar mesally. The more you move the molar mesally, the more the difficulty. So sometimes I have to use the TAS, just like the last question, the question before. I have answered some about it. TAS may be necessary for this kind of case, and also I will use a short vertical elastic in the posterior area, up and lower vertical elastic. In the whole treatment, during the whole treatment duration, to activate, there is a vertical force component to help or to prevent the molar tipping forward. So this is my experience for this kind of case, and also the bed RAM is very important for the patient to use it. To always keep the aligner fit. Aligner fitting is very important for this kind of case.
Okay. Thank you, Dr. Tian. And we still have one more question from Dr. Kang. And this is for the A7 particle. Will of those all the 4 key elements will be applied as default if the doctor prescribe the A7 regardless of the case situation.
Yes, it's a default. If the doctor don't have any other preferences for extraction cases, A7 will be default for the case you submitted.
Okay, thank you. And here's another question. There is a device called the George gauge, and it is application to assist you taking the bite registration. Dr. Philip wants to know which thickness is recommended to take the A6 bite registration. Is either 2 milliliter or 5 milliliter.
Yeah, pardon. What? Can you repeat it again?
Okay, there is a device. It's called the George gauge.
Yeah.
And this, I have sent a picture through the through Ding, and this is some device to take the bite registration for the twin block or the A6. So, which size selection is better? Dr. Philip wants to know that.
The size of the gauge?
Yes, the George gauge.
Yeah. I'm sorry to say that I never use that kind of that gauge. I just see in the case submitted by our Australian doctor, some of the doctor use this appliance. So I'm not familiar with this, but they have some identification some 这个叫什么？上面它有那个槽怎么说？凹槽。
And a divot, you mean, or like anatomic curve, something like that.
Yeah. They have the incisor. Yeah, that is upper and lower incisor bite in the suitable place, and you can get the bite registration. I will find a references. I can find references for the doctor.
Okay.
Can ask the question. Yeah.
Okay, and we have some question. It's from our previous interview with Australian and other overseas doctors. So after they have some doctor has go through the A6, they are quite interested in the comparison between the A6 and the leading brand's mandibular advancement solution, the MA. So in terms of indication selection or the clinical outcomes, what's your clinical experiences when using both of those solutions? Because it's designed to resolve the mandibular recession.
Yeah, I know that it's a two different products, and as I just mentioned before, that A6 is we borrowed from the twin block. The mechanism is similar with twin block, and the principle of twin block is that we protrude the mandibular to open and the downward and forward of the mandibular for about altogether about 9 to 10 millimeter. So it will strengthen the muscle and then stimulate the jaw and also the condyle, the TMJ remodeling. So this is a principle. So we advance the mandibular forward at one time in most of the cases. This is based on the principle of twin block. If you advance the mandibular step by step smaller, at one time, it don't have enough muscle stimulation. So but I never, frankly to say, I never try MA. I just do some cases with A6. I think the basic principle, A6 is better, is similar with turn block. It's I think it's benefit for the remodeling of the TMJ from the original position to a new position. It's more, I think it's more stable. So more, it's just not a movement of the mandible, just not the position, the change of the position. It's also the remodeling of TMJ. It's the result, clinical result. I think it's more stable. Yeah, that's my experience.
Okay, and here is the last question. It's the Australian doctor. They have some confusion when selecting the attachment. So many doctors think the traditional, like the rectangular attachment, they like the big bulky one, which gives the patient, give the tooth movement excessive retention or active surface. So they prefer to do the conventional rectangular attachment. They don't like the optimized, the small attachments. So Dr. Tian, based on your experiences, could you brief talk about what's the pros and cons between the optimized attachment and the conventional, like rectangularly attachments? Thank you.
Okay, thank you for the question. Yeah, we have, because I just mentioned that we have the platform Master Force. It's a biomechanical analysis platform. So we have do a lot of research on the biomechanical analysis of attachment, also the conventional rectangular attachment. It's from the because in the past we designed this kind of attachment just based on our experience from the fixed appliances. We thought that the larger should be the better, should be control better. So, but after we have done so many experiments, so many analysis of the biomechanics of the attachment, we found that for the conventional rectangular attachment, the thumb surface is not useful. You don't have any effect on any function to help the movement of the teeth. You know, the attachment, the rectangular attachment is the large size. It's uncomfortable for the patient, and also, and the more this kind of attachment, the more difficult for the patient to wear and to take off the aligner. So we want to optimize to better this kind of experience. So we develop the optimized. It's smaller than the rectangular attachment under the guidance of a Master Force platform. So it's a trial and research for how to develop. It's just okay. It just can feel the work, realize the movement of the teeth. You don't need so large, so big attachment. I know that the optimized attachment is not the best. We are keeping to improving it to anticipate a better result, although we want to make it smaller for the patients to have a very good experience wearing aligners. And I think because of the time, I would maybe we have some time in the future lecture. We can share you more about the biomechanical analysis of the traditional, conventional attachment and the optimized attachment and the clinical result to you. Thank you.
Okay, thank you, Dr. Tian. And by the way, there will be an online lecture on May 10th. Professor Cao will specifically talking about the attachment selection and the corresponding tooth movement. So he will demonstrate the traditional conventional attachment approaches and the optimized attachment approaches with his case demonstration. And due to the time limitation, this is the last question. The Dr. Philip wants to know how to fix or counter the boning effects in the A8 design.
A7 design.
Okay, A7 design. Yes.
Extraction case. How to prevent? The question.
And Dr. Philip, is that what you are asking? The how to counter the boning effects in the A7, the extraction cases?
Yeah. For A7 cases, the key element. Okay, let me share you this. Yeah, this is what we are doing. How to deal with the bone effect. This what do we do?
Dr. Tian, we can't see your screen, the PowerPoint, right? Can you just turn on the screen share?
Okay, I will just let me share. Just share the screen. Can you see me? See the screen?
Yes, we can see the slides. Yes.
Okay, yeah. This is a summary of our A6 protocol. The protocol is all about how to prevent the bone effect. This one for the posteriors taping backward means that in order to prevent this posterior teeth taping nasally during the treatment, and this canine also we overcorrection of angulation of canines to get or to achieve the bodily movement of the canines, and also the overcorrection of torque of anterior teeth is to prevent the retraction. When the retraction the anterior teeth, to prevent the upper lower teeth more to become straight, even taping lingually. That's a kind of bone effect. And also the curve of speed, reverse curve of speed. We design this kind of curve of speed to prevent the deepening of overbite during retraction of anterior teeth. So these are all our protocols are designed to deal with the bone effect.
Okay, thank you, Dr. Tian. Dr. Philippe, is Dr. Tian answer your question well? You can type in or click the required to speak button. Okay, thank you, Dr. Tian. And due to the time limitation, this will be the end of the lecture. I hope you guys enjoyed the lecture from Dr. Tian, and hopefully I will see you soon. And thank you, Dr. Tian, for your 2 hours effort of putting everything, the introduction, the innovation introduction casework through for today's lecture. And at last, thank you guys so much for attending the lecture today. I have posted the Dr. Tian's personal email. If you want to discuss some further question with the Dr. Tian, please feel free to email him. Also, the recording will be available by next Monday. And the last, we will send out the treatment option, some product information to your email. Thank you guys so much. That will be the end of the lecture today. Thank you. Thank you, Dr. Tian.
Thank you, Dr.
Thank you, guys.
Everyone. Thank
Have
you
a good night, everyone. Bye-bye.
Bye-bye.